a whole lot of friends after a very long time. So, hi and good evening to all of you. I'm just going to share my screen.
Yeah.
Can you see my screen?
Yes.
Yes.
Okay. So maybe I'll just get started. A brief introduction about myself. I'm batch of 92-94. All Nimish's batch actually. And was in Titan for 10 years. And after that, I joined my partners George and Usha in Icarus. So we are actually two companies, Icarus Design and IcarusNova. Between the two companies, I think we are a sort of a full stack design company, doing everything across branding, packaging, to products, to services, and digital. So the whole genesis of IcarusNova is actually, sometime in the mid 2000s, we got very lucky to sort of get connected to the innovation ecosystem in Bangalore. We started working with a lot of startups and innovators who were all doing lot of very unique grounds up work in the healthcare space. So as we sort of started working with them and getting deeper into it, we realized that the healthcare system here in India is there's actually not much going there. Practically, the public health system is very weak, and private health system is completely money making rackets, and there's really not much going there. So we realized that probably that's on the other side, in terms of Medtech, you had only these very big brands like the G's and the Siemens who were dumping all their global products, in this country. So it looked like there is actually huge gap and huge opportunity, and probably there'll be a lot of exciting work there. So sometime 7-8 years back, we decided to start IcarusNova, which is design-led innovation focused in medtech and healthcare. And it's been a very sort of tough but a very exciting ride. And now we kind of find ourselves in this very unique place where we have this team which is very much focused in this space and is sort of getting to do a lot of new and exciting work in this space. So that's just a little bit of introduction about my company. Just to kind of start the discussion, I thought what might be interesting is to just take the audience through the kind of problems that we are trying to solve today for our clients. The nature of problem solving is actually very, very, very dramatically changed in the last 10 years. What we typically started as solving aesthetic problems, and all of you here will relate to me if I say enclosure designers. We all started our careers as enclosure designers, but very soon, I mean, in the last 10 years, we've realized that designers are being called upon to sort of participate in way more fundamental problem solving in way more sort of meaningful areas. So, just to illustrate the kind of trends that are going on in medtech and healthcare, I've just picked up some 5 very broad trends through the kind of work we have got to do, just to sort of share with you all the kind of really new and exciting work that is happening in this space. This is the first thing that I wanted to talk about is connected systems, and I don't think this is anything new to people. Everybody is aware of it, and probably all of you are using some system like this already. Either it is Fitbit or whatever of the sorts. One such project that I would like to sort of take you in detail is this, which we have done for a company called Life Signals. If you're aware of Holter test, Holter is actually a product for people with cardiac problems when the clinicians want to get a prolonged kind of performance of the heart for a week or 5 days or something like that. What they do is they put on some leads on the chest and they send the patient home with one big device which the patient is supposed to kind of hook it onto their trouser or put it in their pocket and walk around for a week, so that those leads are continuously collecting the data and it gets stored in that big device. He has to then take it back after 1 week to the hospital. Then the doctor downloads the data from that and tries to understand what may be happening to his heart over the period of that week. So this company actually started by thinking, how can we get rid of that messy, bulky device and come up with something very small and wireless and handy, so that it's easy for the patient to wear it for 1 week and go about their life in a normal manner. So they came up with a chip, which is a wireless chip, and it acts like a 3-lead ECG. So the engagement with that client actually started with that Holter replacement, which was the first biosensor. So what you see there is this, what you see here is a patch which actually kind of gets pasted onto the chest, and it has the leads in that, and then this patch or biosensor communicates wirelessly to the phone, and the data is constantly sort of transmitted to the phone and shared via the phone through the cloud. So this was the starting of this thing. The Holter then went on to become many biosensors, the latest of which is actually a kind of a 5-parameter biosensor, which has a temperature and heart rate and respiratory rate as well as SpO2, and is currently being used as a non-contact COVID monitoring patch actually. So slowly what started as one small, replacement for a Holter is now mushroomed into multiple products such as these. And there are already about 4 to 5 biosensors which have been designed for various applications. And the next one in line is actually a similar wireless 12-lead ECG, which will no longer require, any technician to actually come and put the leads. And it is very easy, self-application kind of a lead. And again, that will connect to the mobile phone. And, then it connects to the cloud, therefore remote monitoring is possible. So again, here, what was a small relationship that started with this client as just the product design of the biosensor soon went on to become product design for multiple biosensors, went on to become multiple relay app design, which would probably be a app for a mobile device, went on to become the, went on to be the web app design for us as well. And there are many forms of web app because the application now is kind of starting to be for clinicians in the hospital as well as for patients at home to be used on by themselves. So this entire, range of this entire remote monitoring system was something that was designed by us. And this is, I'm just giving you 1 or 2 examples from what we have done, but I'm sure this is an area which everybody is already very, very familiar with, including things like, insulin pumps and implants where, from the mobile phone, the implant gets messages and it's able to kind of inject the right amount of insulin at that point in time. So there are many such devices that are now coming up and lots of work going on in this space. The next big trend and area that I thought of sort of highlighting was this whole screening and task shifting area. So it's no news that this whole ratio of patients to experts, patients to clinicians is very skewed, especially in countries like ours and developing countries. So it's one doctor for many thousand patients. So a lot of people are actually trying to work in this area to see that what of the doctor's activities, what of the doctor's tasks can be taken away from him so that he can be better utilized to actually focus on diagnosis and treatment. There are lots of things that a doctor and a clinician does which actually does not have to be done by them. So that is why this whole area is called task shifting. So identify things that the doctor is actually wasting his time on or underutilized because of him having to do that, and therefore get alternative resources to actually do that. So lots of people are working on areas where things can be done by minimally trained health workers, maybe by paramedics. So this is a whole big area, and this is a problem which is very, very sort of typical to our country, typical to developing countries, and therefore solutions are also kind of emerging from these areas. So lots of startups are working in this area. One such example that I would like to share is this device called Intraview, which we have designed for this company called Medtronic. In ENT area as well, the ratio of ENT surgeons and ENT experts to patient is very, very poor. Coupled to that is the fact that ear itself is a very, very neglected area, unlike the eye. If there is any small problem with the eye, people do go to a doctor and get some treatment. But ear is something people neglect till it becomes almost like a hearing loss or some very irreversible problem. So this company actually had the ambition to provide some kind of a complete care in the middle ear infection area for people in like lower socioeconomic class, because that's the class where there is more neglect, and typically children will have oozing ears and it will just be neglected till that child cannot hear on that one side. So their ambition was to kind of provide some kind of a complete service for this class of people in this middle ear infection diagnosis and treatment. So this device is again actually a mobile phone based device, but it's more than that because it's an extremely simple device which with a couple of days of training anybody can start using it. So it is given to minimally trained health workers who actually go door to door screening patients. So they go to every home, they screen patients, and if they see that anybody has any problem, they take images of the tympanic membrane and they kind of transmit it to the hospital till they get some kind of a feedback saying whether this patient needs to be brought to the hospital or some local treatment can be given to the patient. So the challenge here was to actually sort of make the device and this whole service model so simple that lots of volunteers and lots of minimally trained health workers can just go and do this door-to-door kind of screening. The challenge here was also to redesign the optics to such a kind of a simple form, because otherwise optics are typically very sensitive and not rugged, and therefore for field conditions they just do not work. So we had to redesign this optics to make it something very rugged and also cheap. So therefore, using plastic lens and the entire thing is a very compact handheld mobile phone based device which has its own lighting, and it works for about 8 hours. So health workers just take it out in the morning and they just go house after house and they keep taking pictures and they keep uploading till till they come back, and then they start figuring out which patient needs to be taken back to the hospital and things like that. So this whole area of what shall I say, task shifting, because otherwise this is a problem where the patient will have to go to the hospital, then the doctor will inspect the ears, and then the doctor will decide that the patient needs antibiotics or the patient needs anything else. So this whole part of figuring out whether the patient needs to go to the hospital or not has been taken away from that doctor's tasks, and minimally trained health workers are now facilitating that whole process. We have done something similar like this in the eye area, and we have done something similar even in the gynae area. So lots of work going on in this screening space. The third kind of large area which I wanted to highlight was this whole thing about changing patient journeys. So the way healthcare is in this country, and I suppose in many other countries also, hospitals are huge monoliths which are providing services for anything and everything. If you have a fracture, you go to the hospital. If you have fever, you go to the hospital. If you have cancer, you go to the hospital. And if you need to deliver, you go to the hospital. So primarily, they are huge institutions which are everything for everybody, and that is how healthcare is developed in this country. But I think slowly, lots of healthcare brand owners are kind of taking a step back and trying to see this whole, service delivery can be broken up into smaller, more specific experiences. I think one of the things which people may be very familiar with is this whole birthing focused hospitals like Motherhood and Cloud9. So for most part of pregnancy and delivery, the mother is actually not a patient. So there's no need for the mother to be treated like a patient in a large hospital like Manipal, and the whole experience being more traumatic than actually something to be celebrated. So people like Cloud9 and Motherhood and all are changing that whole experience completely by saying that we start building a relationship with the mother when she is expecting, and through the 9 months we have a relationship, we facilitate a very easy delivery, and then we carry forward the relationship post she has delivered by providing child services. And so they are really changing this paradigm of how pregnancy and delivery is treated, instead of it all getting bundled in in the same kind of care in large healthcare, large hospitals. So in this area, one thing that I wanted to share is something that we have done recently, and actually the whole thing got launched through the lockdown last year. And so this is a voluntary cancer screening center, which is called Neura, and it is a Fujifilm venture, actually, Fujifilm of Japan. So the client's primary intent was that in Japan, cancer screening, voluntary cancer screening is something that happens, is part of the culture, and it happens every year. People just go there, and after a certain age, they go every year, and before that, every 2 years, they go there to these screening centers, and they voluntarily get themselves tested for a bunch of common cancers. And this is a practice which is there in many parts of the world. And so Fujifilm felt that maybe, India is also sort of ready for something like this. So they wanted to, this is their pilot, this is their first center here in India. So we kind of worked with them right in the beginning, and initial research that we had done actually pointed to the fact that we are probably not ready for something like voluntary screening, because culturally we have a whole lot of fear and issues with cancer. There were lots of things that were leading to the patients feeling actually they are not patients, because this is voluntary screening and this is something a healthy person has to go through. So there were fears like uh, uh, I mean, first of all, if I have some family history, it's possible that I might also be susceptible. So I don't mind getting myself screened every now and then. But the whole thought of going and standing in a standard diagnostic center where I am waiting with whole lot of other people who have worse disease, and the trauma of having to wait one whole day there. So the whole experience of going to a standard diagnostic center was extremely not happening, because of which they were neglecting and not getting screening done at all. On top of that, there were also issues, fear of radiation itself. Is radiation good for you and not good for you? Then, of course, to boot, there is the fear that in case if the results are positive, then how do I deal with it? So essentially, we seem to be a culture full of fear factor and full of the fatalism and things like that. So the challenge was to actually see how we could design this whole service and sort of flip this whole fear into something which can make them start voluntarily getting their screening done. So we started by saying that this is a service where you don't need a prescription. You don't have to go to a doctor and tell your family history and then reveal your fears and then say that okay, should I get a scan done? And typically doctors will say, okay, you go to this scanning center. So you don't need to worry about that at all. You don't need any prescription. It is very advanced technology and low dose radiation, and hence it is safe for you. And the whole experience was sort of designed in such a way that you can actually pre-book, sitting at home through the net. You can just pre-book when you want to go in for the scan. Once you reach there, it's like you get a strip that you wear around your wrist, where your sequence of scanning is completely laid out, and through that itself it guides you one after the other. And it's almost like once you get in and you get the 4 scans done, and then you come to a station where all your reports are ready, and you meet the doctor and you take your reports and you go. So it was like a very sort of mostly self-service, but then there is always somebody to help you if you run into any trouble, so that you are just by yourself, and it's a very calming experience, and you are just by yourself and you go through the whole scan and then you come out. Very contrary to the kind of diagnostic center experiences that people were going through now. So this is something which has just recently been launched. Another sort of a big trend that we have been very involved in is this complete new care models, So partly from what I was explaining earlier also, this whole thing about hospitals trying to cater to anybody and everybody is actually making healthcare very inaccessible. especially for people in the lower socioeconomic class who obviously, cannot come to these points of care. And even when they can come, they are probably expensive and not affordable. So, especially in the public health area, lots of innovation is going on in new care models. So, companies, brand owners, lot of not-for-profits are trying to come up with radically different care models so that people are able to sort of, access it, and it is also affordable in the process. This is something, again, it was a very, very sort of a long engagement for us, and it had many, many parts to it. I'm just going to sort of quickly take you through it, and later on, if people do have any specific questions about this, then we can discuss it. This is the sort of a care delivery platform for the management of NCDs, which is non-communicable diseases. But this company wanted to start with diabetes and hypertension, because NCDs is becoming as big a problem as, say, communicable diseases, because more and more people are getting diabetic, younger and younger people are getting diabetic, and progression of the disease is very drastic. So it is becoming a huge problem, and again, lots of people are trying to grapple with what to do in this area. So this company actually, Medtronic Labs, came to us with a very, very, very high vision. They said that they want to launch a kind of a complete care delivery model for management of diabetes and hypertension, again in the lower socioeconomic class. And they wanted to participate in the entire cycle of care, not just diagnosis or not just medicines or not just, so they wanted to participate in the entire cycle of care. And they also wanted to sort of pilot it in Bangalore. So the brief was extremely daunting as far as, we were concerned, because it was a very, very high mandate and a very broad vision. And we initially really, didn't know how to go about this. So what we did is, in the first phase, we recruited about 15 patients. We recruited 15 patients who were either diabetic or hypertensive or both. And we sort of worked with them for 2.5 months. We just tried to follow their whole pattern of, how they get themselves tested, where they go and get themselves tested, what medicines they get, what is their practice in terms of compliance to medicine, what is their lifestyle, what do they eat. For 2.5 months, we followed these patients practically, day in and day out, to try and understand what is it that we can do for them in this space. Because just saying, management of diabetes and hypertension is just too vast. So how do we kind of start giving some form and shape to this problem? So based on that first 2.5 months of research, we realized that chronic disease like diabetes and hypertension is very different from, say, malaria or typhoid or dengue fever, or it's very different. But the attitude of people to it is the same. In the sense, people don't understand the difference between chronic disease and non-chronic disease. The fact of the matter is, if you become diabetic, you are more or less, with it for the rest of your life. You have to come to terms with the fact that you are diabetic, and you have to learn to deal with it for the rest of your lives. But people, because of lack of awareness and lack of understanding, and more so in this socioeconomic class, don't understand the difference. So they they figure out they are diabetic, they are given some medicines, they have medicines for some time, then the number becomes okay, then they stop having the medicines. So the whole approach and attitude to chronic diseases is different, but people are not really aware of it. The other, if you are aware of it, there is the huge stigma and almost some kind of a doom that sets in that, oh my God, now you have it for life, you're gone. It is very expensive. You have to go on eating medicines for the rest of your life, and therefore, this is a gone case. And then people just out of doom, feeling of doom, just stop having medicines. And the third most important thing we learned is that women are way more vulnerable in this particular treatment, trajectory than men. What happens is like men, somehow since they have some symptoms or something like that, they just go and get themselves tested and they start having medicines, and they have the priority over the woman. Women rarely go and get themselves tested. Even if they are tested diabetic, they are told that, okay, you have, medicines for 1 month and you are okay now, just stop it. Either the husband doesn't give money it's just appalling to see that the women barely get tested. So based on all this insights, we did a next level of sort of a very detailed research with only women. So what we did is we recruited about 15 women and started working with them and started testing out a whole lot of interventions with them. So the reason we chose these 15 women was because they all belonged to a self-help group, and they were all, in some like microfinance group or the other together. And we realized that the group dynamics was extremely important to deal with something like a chronic disease, where they can help each other out and, motivate each other to kind of sustain through the whole treatment plan. So through this 2.5 months with these 15 women, we tried interventions like, testing of all their parameters. This would be done by a health worker who was actually facilitated with a tablet, as well as a whole lot of point of care devices like you're seeing in the image here. So this health worker herself could test all their parameters. The second intervention we tried were medications, and they would be given medications for only 1 week in a sort of a pouch, where you can clearly communicate to them that this has to be had in the morning and this in the evening, this before meals, that after meals, so that it's very easy for them to follow that. But only 1 week's medication would be given to them. Along with that, we also tried doctor consultations, which was to begin with in person, so that the doctor and the patient know each other and there's some kind of a trust that is built. And then over a period of time, that was carried on through teleconsults. And the fourth thing that we tried with them was interventions to teach them to change their lifestyle. Essentially, all teaching them about sugar and oil and role of exercise in diabetes and all the lifestyle related interventions, and what that role of that in diabetes is, and what may cause progression. And so we tried all these 4 interventions with them in these 2.5 months, and the outcome was extremely positive, and the uptake of this whole methodology was very good. So this was then converted into a proper program, which is carried out by this health worker, and a group of women have something called the group leader, who keeps tab of what the sessions are, and it was converted into a sort of a curriculum of 8 weeks, where they are taught how to take care of their own diabetes, as well as given medications and doctor consultations. So this has again been piloted in Bangalore, and I think there are already about 5-6 circles like this which are now going on. So here, since this explanation, this project actually was almost about 1.5 years for us. So starting from the research to coming up with this whole interventions and what are the roles and who will do what, and then kind of bringing it down to sort of digital intervention for each of those roles. The health worker has a tablet, and in the tablet she has the profiles of all the members that are there in the circle, and what are the parameters of each of those members, and who has had what medicine. All that data, patient data, is all with her in that tablet. The doctor has a laptop, and the doctor app is there. So the doctor, again, the minute the patient comes in, the doctor can see the history and sort of continue the medication based on what the doctor sees on the doctor app. And one person who's the leader of the group also has a small app, mobile app, which is primarily to remind each of these members to come for the meeting and then to come and take their medicines and things like that. So we kind of designed all parts of it: the technology, the service design, all these kits that are being carried by them, and the whole system was designed by us.
Sapna, quick time check. So we have about 20 minutes more.
Okay. So this is I am more or less done. So this is the last theme that I wanted to just highlight. This is more in the space of so what's happening is with the technology kind of become so intrusive and exponentially changing. There is a huge attitudinal change even in the clinicians and in the healthcare providers, where they are little open to seeing if these kind of digital interventions can also be embedded into their therapy, we can say, specifically in the mental health space. So this is again something which is just got launched on Sunday by Nimhans. This is a app called Mind Notes, and what it does is for people who are sort of experiencing psychological distress but are hesitating professional help. This is something which is prescribed by the psychotherapists, and they are told to assess themselves through this app, kind of understand their own condition, maybe try and use some of the self-help tools that are there and see if the problem goes away. If it does not go away, there is a small kind of a like a bridge module where they can first chat with a professional, healthcare professional, and if they can overcome their barriers, then they can actually have a call also and try and get comfortable with the with a psychotherapist, and then eventually sort of plan to go and meet the psychotherapist. So this is again this whole area of digital therapeutics, which are now being what shall I say, adopted even by clinicians, something to augment their therapy and their care plan. So those were some of the broad themes I just wanted to kind of highlight through our work. I'm just showing you some of the things, and there are lots and lots happening in this space. So the exciting new things that we are right now sort of in the process of looking for projects and kind of identifying areas are this big area of trying to improve health-seeking behavior itself. So Medtech is trying to improve accessibility but unless and until people have some, motivation to sort of improve their, health-seeking behavior, it's not going to really, make how much ever access will be improved, there'll be no takers for it. So there is this whole area where, there's a lot of exciting work going on. The other big area is this space where no longer are patients what they used to be, where they would think that the doctor is God and the God said so, and therefore I have to have this surgery or I have to do this. More and more patients are becoming very aware of options and very aware of alternative solutions. So the whole, healthcare system has to start co-opting patients into their care, and particularly so if it is, things like NCDs, which are very long duration. So this whole area where I think design has a lot to offer. Again, there is this whole area of early detection and prevention, for which lots and lots of technologies are coming up, and people are trying to, implement them. Things like easy oral care scanning, easy cervical cancer scanning, and lots of things, so that things can be caught early, and therefore something can be done about it before it becomes too complicated and expensive to deal with. And of course, there is also this huge space of health information and education, because I think we all experienced it also through COVID, that misinformation and lack of information can cause a whole lot of problems. So how to improve general awareness about health and general awareness about options that are available is again a very big area where lots of work is going on. I think with that, I just would like to stop here. So the whole, I just thought I'll highlight some of the interesting work that is going on in this space. So, because I'm not very sure whether it's something that too many people are into, and we actually find ourselves quite, very few people are too focused in this space.
So, Sapna, that was a really interesting talk. I think we have a lot of questions. So, Zayed, do you have the first question?
Yes. So, can you hear me?
Yes.
I do. I can.
So yeah, obviously you've done so much work in the medical field and all of this in the Medtech field as a designer. But my question is, when you are working on such large problems, especially a problem where people's health is at stake, like in chronic diseases and other diseases as well, when you are studying the system as a whole, how do you, as a designer, narrow down and be like, okay, this is the problem I want to solve? Because as a designer, you feel like, okay, you're empathizing with all of these stakeholders, and you want all of the users to feel better, and you want to solve each of their problems. But your product, if it becomes vague, if you're trying to solve too many problems, it becomes too vague. Like you're not going to get the users to be able to use it, the specific users. How do you end up focusing on just one problem and like blindsiding everything else and be like, okay, this is the problem I want to solve, and this is how I'm going to do it? Because I also I'm working on
Zayed, you need to
you
need to summarize.
Sorry.
Yeah,
that's
so. One thing is, I must confess, we are a consultancy, so we actually provide this service for clients. So clients also come with their own agenda and their own vision and their own intent. But having said that, I think we try to use lots of actual prototyping and testing, and there is that rigorous research part which I mentioned to you about that NCD project. So there is research. When we kind of synthesize the research. It is a collaborative process. The client is there, we are there, and we try and use a lot of unique tools which we've kind of built over a period of time. When I say built, what I mean is we used over a period of time to bring alive a lot of things and try and help the decision making process. And we make sure that it doesn't get hijacked in a certain way, which is either can it be brought fast to market, will it be cheap, or will it be so we have just because also over a period of time we have experience and we have lots of evidence in that sense to bolster our argument. We kind of help these kind of decision making. But having said that, sometimes it could go in a very sort of a narrow path also, and you try to do the best, and in most cases people do come around, and especially if you have protos, like in that Intraview case, we had 40 protos which were built and given to the field for 6 months, and then if somebody comes back saying that this is easy to use, there is no question about not being it. So we kind of facilitate the process of decision making, but there is always a chance that some other priority might kind of hijack it. Yeah, it's a very difficult thing, because you always have to do this and that, and everybody wants to do more with what you are doing, but it can be done.
So Sapna, I think we have a question from Ravi Krishnan. Ravi Krishnan, would you want to tell your question? I think the question is that how did you get into this field?
So even now we do other things also. But as an organization, we feel that we are quite suited to this kind of problem space. It's first of all, there's a lot of grounds up work that's happening here. We are pretty excited by this kind of problems. Then they're all very slow and long problem solving processes, and we feel that we can contribute to this kind of a space, and that's why we decided to focus in it, and almost that's why we decided to start a new company and build capabilities that are required for it.
Mm-hmm. Actually, the question was how difficult it was as a designer to immerse in field which is so specialized. And what did it take for you to start feeling that you can contribute? Because it's a highly specialized field, and I know there's an enormous amount of engagement that is required for you to feel that I am now equipped to contribute. I was just wanting to understand, and how did you deal with that?
I think in the early years, in mid 2000s, and till we started IcarusNova, which is 2013 actually. We were working with a lot of entrepreneurs and startups and innovators. In fact, we got lucky to start working with a lot of doctors. Doctors are great innovators, and somehow we landed up working with a couple of them, and then we felt like there are lots of things to be done here. There are lots of problems to be solved, and anything you take, like whether it is devices or whether it is hospital furniture or space or infrastructure, anything you take, what we have is very basic. What is available is very basic. So we started to work with doctors. We would go to hospitals, we would go to outreach centers and all that, and it felt like we kind of connected with those kind of problems, and the way we could contribute, and the doctors were, the way they were responding, it was all quite positive. But having said that, it took us quite some time to then come to the conclusion that okay, let's focus only on this, because viability wise, it's very slow in terms of becoming viable. So that was a conflict in terms of, should we just focus here and then, therefore, how will it become viable? But it was a bet which we took at that point in time. And I'm happy to say that the kind of work we've been able to do has been extremely satisfying. And we feel that now, we are only getting better and better work. And it's been motivating in that sense.
Okay. I think we have the next question from Sunil Kumar.
Yeah. I'm sorry, I don't know if I answered your question, but...
No, it needs a long answer.
One more IDC chai we need to have.
Exactly.
Yeah. So Sapna, thank you for your taking us through your journey. So I am also taking some very baby steps, initial steps into ID things. So what I the projects I get is varied. Like one is for a hearing device, which you did for the bottom of the pyramid kind of an application. The other is what I'm working is on a UI device for a ventilator. So all of these are of different areas. It's not just focused on one particular area. And each time you need to struggle with what standards to adhere to and what are the certification requirements you've got. Is there any easy way of going about it?
Okay. Sorry, there's no easy way in this area. The reality is that it's a complex space. It is ridden with lots of regulatory requirements, and on the other hand, there's nothing. In India, if you see, there are anything that can pass. But if you want to do something of quality and repute, it is highly sort of guided by a whole lot of these certifications, and there is no easy way out in this. And what has helped us is we've got some good partnerships actually. So we got some good consultants for at some point in time, and then we've kind of kept in touch with them, and we take a lot of inputs from them, because we can't do everything. I think we'll also have to figure out what we want to focus on. So we say, the research, the design part is what we have in-house and we focus on. But slowly we've built an ecosystem of consultants and well-wishers, and so we kind of use a lot of inputs from them as and when required.
Okay, so it's not a straightforward answer.
It's not straightforward, but I think collaboration is probably the way out, because you're definitely not, because what you do for the ENT space is not something you can directly apply for cancer, or directly apply for dialysis for that matter, or so that way collaboration is probably the best way to quickly cover some ground.
Thank you.
So hi, Sapna, Prakash here. I just have one observation, maybe you can clarify. Am I audible?
Yeah.
So the handheld device which for ear cleaning that you showed, where you're trying to screen and take a look. From ergonomics point of view, when I look at the picture, I felt that's too big for a handheld device. Am I right to say that, or did I?
No. I think the image is probably doesn't have a reference. It's exactly, so it's got a mobile phone, and it's exactly as big as the palm, and that too designed for a lady's palm in the sense. It's actually a small device. It doesn't. I think the image doesn't do justice to the scale, but it's a small device. In fact, a whole lot of challenge in that particular project was to sort of bring weight down, make it very rugged, aim and shoot. She's not going to have time to go and adjust and focus and all that. Aim and shoot. All those things were sort of very important inputs in that.
So yeah, exactly, because you mentioned about this mobile screen kind of device. So would it make us, I'm just thinking aloud, would it make a sense to keep these two things separate? The device which you insert in the ear to scan or screen, and the where you see the visual part of it. So that I don't know whether it's possible, feasible, no idea. I'm just looking, because The current one, which are, if you go to ENT specialist, I just visited maybe 20 days back, and they had a standalone kind of unit, which is there in almost every ENT clinic you go, they'll have this. And I found that's very kind of, it's like almost like a stylus which he holds, and then he can see the entire.
So that was actually the starting point, and this again we work with an ENT doctor in St. John's. So that is how the ENT doctors are able to examine, because they have the patient lying down. Typically, they'll have the patient lying down, or they may even make them sit, and then he uses that probe, and then he sees the whole thing in a big TV or somewhere else, that is the typical hospital model. But all this come into one small device, because she also is using that, because she is very minimally trained. She's also using that visual to figure out when to take the image, and so she's also navigating through that. Therefore, all this needed to be together, and we also wanted to make a single device, so that charging, you charge one device and you take care of one device. The more you kind of complicate a field health worker's life by saying isko bhi charge karo, usko bhi charge karo and all, it becomes a problem. So initial models, there were both models, they were this separate as well as together and all, but finally this felt like a more optimal solution for a field health worker to use.
Oh, thank you.
So I think we might have time for just one last question.
Hey, hi, Saurabh here. I wanted to ask whether we can see IR sensors integration, in the mobile phones as well nowadays, to 3D scan or to create a low poly model of things around us. So does implementation of this particular technology sounds relevant in the ER module or the range?
So, sorry, your question is?
I wanted to ask, since it's the probe which you had made to inspect the ear, does it also has the capability to scan the ear canal, or is it just a regular imaging sensor?
No. Actually, technically, ear as an organ, other than wax which fills up the canal, there is nothing. At the end of the canal, you have the tympanic membrane, and the visualization of that membrane can tell you what is happening on the other side very, very clearly. So all you need is the image of the tympanic membrane. So this doesn't have a 3D scanner and all. It doesn't have.
Yeah. Can I just add to that thing? Since I worked on the same similar project, what we had done was we were using sonar sensors. So it became
So based on the reflection, you will know what's the pathology on the other side.
Yeah. It was AI algorithm learning software.
Okay.
Based on it, we were using, just to answer, IR is not the solution for everything. You can make use of other sensors which are more relevant to that particular organ.
Okay. That I get. Yeah.
Because recently my brother was diagnosed with some ear infection, which later on developed into a knot, and we all got very worried because it was sent to biopsy and everything. So,
I see.
Because initially the assessment which the doctor did were wrong. The 3-4 times he had visited the doctor, and that is where I just wanted to ask, can this be the solution to just scan it from the inside and take a proper look at it than that of letting it develop?
I think there are other devices which do that, but in this particular application, it was not really. See, first of all, it's door-to-door screening being done by somebody like that minimally trained health worker. Primarily, you're trying to spot some very basic problems, whether the tympanic membrane is perforated, whether there is an infection and therefore there is some effusion. So there are some 2-3 basic problems that you are trying to identify. It may, definitely not to diagnose any further more more
Detailed.
complicated, more complicated issues.
So one more part is your ear tunnel is kind of whirled. I mean, it will not. It's not like a straight line.
It
So
is
your
a
IR,
curve. It is a curve.
it's a curve. So IR will not travel that thing. So it is only a site of line. So maybe IR may not be the right sensor over there.
Okay.
But we had to do a lot of study because our scope is straight. So therefore, the protocol is that they pull the ear up, and then when you pull the ear up, the canal kind of becomes straight, and then they aim and shoot. So that was the protocol that we had trained them for.
Yeah.
Okay. Thanks so much, Sapna.
Sapna,
Nice.
thank you for the talk.
Nice.
Yeah, I think it was very insightful. A lot of things I think we all learned from this. A lot of things we got to know, and
Thanks a
of
lot.
course,
Yeah.
good to connect back after so many years. So
Yeah, it was good, Sapna. Great to listen to you after a long time because I missed your lecture in the Pune Design Festival.
Oh yes.
Yeah, it was nice.
Great to see you all after so long.
Yes.
Dr. Sapna, great talk. We should add an MD to the end of your name.
yeah, maybe in a few years.
कोशिश कर रहे हैं. I'm trying.
ठीक है. Thanks Sapna. Thanks everyone.
Thanks a lot. Thanks, Nimish. Once again, thank you all.
Thank you,
Bye.
Sapna.
Yeah.
Bye.
So
Bye.
let's connect
Thank you,
back
bye.
Thank you.
next week.
Bye-bye.
Bye.
Thank you.
See you guys.
Bye.
Thank you, Sapna. Thank you, everyone.
Thanks, Nimesh. Bye.
Thank you, Nimish. Bye bye. See you again. Take care.